Hello, everybody. My name is Dr. Rajesh Shah. Welcome to my YouTube channel, Expert Urologic Pathology. In this channel, I try to bring to you simplified approaches to urologic cancer diagnosis, high-yield topics, and frequently try to bring newer emerging science. So today I would like to discuss with you a very important white paper that is recently published by two leading urologic pathology society, GUPS and ISUP. So let us understand first some background. Prostate cancer is highly heterogeneous disease. It is in fact one of the most heterogeneous human cancers. In Western world, over 80% of new diagnoses are triggered by abnormal or elevated PSA, and they are clinically localized without any digital rectal abnormality or any. So basically, they are localized cancers, low stage cancers, low grade cancers. Many has indolent biological behavior with excellent 10-year disease specific survival greater than 90%. So in this particular group of patient, active surveillance should be the mainstay of treatment. Now, despite improved risk assessment and uptake in acceptance of conservative management like active surveillance, overdiagnosis and overtreatment of indolent prostate cancer remain a significant healthcare problem. This has led to proposal to rename grade group 1 prostate cancer as a non-cancer with rational arguments both for the change and against the change from clinical colleagues as well as pathologists. And again, my idea is not to go into this debate today. This has been extensively covered in the literature. So that is not the purpose of this white paper. Our particular objectives for the white paper were to help identify a path toward a more meaningful multidisciplinary solution addressing the continuing problem of overdiagnosis of indolent prostate cancer and its resulting downstream negative effects. Again, as I mentioned to you, our emphasis is not on grade group 1 renaming debate. And we wanted to review the evidence base regarding the current state, limitations, gaps, and future directions in detecting the indolent prostate cancer. So 29 expert urologic pathologists, particularly with prostate cancer expertise, were invited to be a panel of this white paper. And there are two white papers. One is a more clinically angled or clinically targeted platinum opinion, which came out in European Urology, and a very detailed full version of this opinion paper has now come out in American Journal of Surgical Pathology. So I definitely encourage you to read this more in detail. But in this video, I will try to simplify what we are trying to say. So the structure of the white paper is divided into 4 components. We issued multiple statements reflecting first the definition of indolent prostate cancer. Then we made an argument that can we detect indolent prostate cancer? Can indolent prostate cancer be reliably detected at biopsy? And finally, how can we improve our ability to correctly classify indolent prostate cancer at biopsy? So I will go over critical high points on all these 4 components. So first, the definition of indolent prostate cancer is a well-differentiated acinar neoplasm with invasive histologic features. So indolent prostate cancer by definition is still cancer by pathological definition, but that do not spread outside the prostate, become symptomatic or shorten a patient's life if left untreated. And I think that makes a lot of sense when we talk about indolent nature of a particular cancer. Second argument is that can indolent prostate cancer be detected adequately? And the answer to that is yes, but only on entirely resected prostate tissue. So why like that? Based on the 3 pieces of data. First, we know that in entirely examined radical prostatectomy, grade group 1 prostate cancer has exceptionally outcomes. Most importantly, there is no metastasis to lymph nodes or distant sites, and no cancer-specific death has been reported. Second, most incidentally detected prostate cancer in cystoprostatectomy specimen removed for bladder cancer has shown that they meet clinically insignificant prostate cancer criteria. Third, in multifocal prostate cancer setting, non-index tumors typically meet clinically insignificant criteria. So in multifocal prostate cancer, tumor volume, tumor grade, and pathologic stage are almost invariably defined by index lesion of the specimen. So typically we considered index lesion as the most significant, while the non-index part of the multifocality, they are typically low grade and clinically insignificant. So based on this argument, the one statement that can be summarized is that in clinically insignificant prostate cancer criteria capture many indolent prostate cancers. However, the same clinically insignificant criteria also encompass early phase non-indolent prostate cancers that subsequently may progress during active surveillance and potentially merit definitive treatment. Therefore, not all clinically insignificant prostate cancers are indolent prostate cancers. One can define indolent prostate cancer only in the setting of an entirely resected tumor that shows the characteristics of clinically insignificant cancer. Now, can we identify indolent prostate cancer in biopsy? An answer is no. A grade group 1 prostate cancer diagnosis on needle biopsy is not always identical to one from radical prostatectomy. Why? Because recognition of indolent prostate cancer cannot be made based on some of the arguments that I'm going to share with you. So first argument is that we know that despite combination of MRI targeted and systemic biopsies, which has shown to improve the detection of clinically significant prostate cancer, men who choose to undergo radical prostatectomy as a treatment has shown to have substantial upgrading, typically about 22 to 27% of patients with biopsy grade group 1 prostate cancer. So this is a very important piece of data. And this upgrading can occur because of a previously unsampled higher grade component, temporal progression of the same tumor, or de novo high grade cancer. The third argument is that a small subset of grade group 1 prostate cancer at needle biopsy is associated with prostate cancer specific mortality. In an interesting study from a Danish population, of an unselected cohort of men with untreated grade group 1 prostate cancer specific mortality at 15 years was 14%. And this is a quite alarming data, but I think does not make sense. And these findings should be interpreted cautiously, as the study did not implement a central pathology review. So I think very likely there is a contamination of the higher grade tumors in this particular cohort. But one fact that we can, I think, perhaps summarize is that even if the mortality is low, death can occur using active surveillance criteria or a clinically insignificant definition. And therefore, the definitive diagnosis of indolent prostate cancer cannot be reliably made on needle biopsy. Fourth argument is that higher inter-observer variation occurs in diagnosing a subset of Gleason pattern 4. And I think this is very common for certain type of sub-patterns. Pathologists are very familiar with this issue, particularly sub-patterns of pattern 4, such as poorly formed glands pattern, fused glands pattern, cribriform pattern can be significantly non-reproducible even within the experts. But I think same time, this variation can be reduced by ensuring novel and structured quality improvement process in an anatomic pathology laboratory. So what are those quality processes that you should implement? First, you can use intra-departmental consultation or consensus conference model. This is very commonly utilized in many laboratories. Disease focus review could be a very good process where I think a group of pathologists in a team intensely review the problem and then try to use the same criteria to diagnose and can reduce the variation. Second opinion from an expert can also be important. Also, it is important to understand that in borderline cases, precision is not possible, but appropriate communication with the urologist may help guide appropriate patient management. And I think in this type of setting, percent pattern for estimation can also be helpful. The fifth argument is that a subset of grade group 1 prostate cancer harbors molecular alterations present in higher grade and aggressive prostate cancer. So if we look at the molecular studies of Gleason pattern 3 and pattern 4 tumors that are in proximity, they often show evidence of a clonal relationship. Gleason pattern 3 regions that are part of larger grade group 3 and grade group 4 prostate cancer show an increased incidence of molecular changes such as P10 loss, 8P loss, 8Q20 for MIG gain compared to those detected in Gleason pattern 3 lesions from grade group 1 prostate cancer. So there is clearly a clonal evaluation of some of these more significant molecular abnormality in particularly when Gleason pattern 3 is a part of a higher grade group disease like grade group 3 or grade group 4. P10 loss and germline mutation in ATM and BRCA1/2 have been associated with grade reclassification in active surveillance for prostate cancer as well as upgrading at prostatectomy. So these are all very important piece of data suggesting that you really cannot figure out just based on the morphology that patient may have a higher risk prostate cancer. Racial disparities are also likely to contribute to biological diversity in prostate cancer. So we know that Black men are more likely to be diagnosed with prostate cancer. In this patient, cancer presents at an earlier age and have a higher risk for locally advanced or metastatic risk. Grade group 1 prostate cancer in Black men has a higher genomic risk scores than in white men. So I think racial disparities is clearly very, very important, and knowing that racial disparities can be very helpful to define your strategy. So the summary from this particular piece of data that I shared with you, you can make an argument that the very low mortality from prostate cancer for men in multiple series of active surveillance results from having both indolent prostate cancers and preemptively treated non-indolent prostate cancers in the cohort. The latter are identified through the reclassification during the active surveillance. Therefore, a distinction between indolent and non-indolent prostate cancer in biopsies before reclassification of the latter is not possible. So this makes a strong argument that why we really cannot identify indolent prostate cancers in biopsy setting. Now let's move to the third topic, final topic. How can we improve our ability to correctly classify indolent prostate cancer at biopsy? An answer to that is that the optimal definition of indolent prostate cancer in needle biopsy can be improved, but only through contemporary multidisciplinary approaches. So this multidisciplinary setting or approach is a very important part to understand that this particular challenge is not only pathologist's problem. It can only be improved if we all party involved in prostate cancer care can come together to define this problem. So let's make some arguments for this, how we can improve this. So a contemporary histopathological definition that captures but does not define the majority of indolent prostate cancer will include. So based on the lot of emerging literature, we came up with a a kind of a definition for indolent prostate cancer, it would be grade group 1 prostate cancer. There should be no equivocal Gleason pattern 3 or pattern 4. So there is no borderline type of situation. No cribriform prostate cancer, that would be big no-no. Intraductal carcinoma, again, big no. No stromal desmoplasia or stromogenic prostate cancer, that many studies have shown that it is associated with high-risk prostate cancer. And this particular definition must be combined with other multidisciplinary factors. So this should not again be looked at in isolation. Basically, pathologists cannot be completely reliably looked at for this particular answer to this particular challenge. I think we have to have multiple pieces of puzzles put together at the same time. The second way you can improve is that you can have a more stringent selection and monitoring criteria for patients who are enrolling in active surveillance. So if we look at this particular study published in European Urology, in contemporary active surveillance cohort of 1,880 men, when stringent selection and monitoring criteria were utilized, the cumulative incidence of prostate cancer specific mortality or metastasis was only 0.1% at both 10-year and 15 years. The 5-year, 10-year, and 15-year cumulative incidence of biopsy grade reclassification was 21%, 30%, and 32% respectively. Older age, self-reported ancestry, particularly Black men, had an increased risk of grade reclassification compared with white men. PSA density and increased cancer volume in biopsy were significantly associated with biopsy grade reclassification, while men who had a multiparametric MRI before enrollment had a lower incidence of biopsy grade reclassification. So I think in this piece of data, basically what we are trying to say is that I think if you have a stringent selection criteria, then I think you can even reduce the biopsy grade reclassification rate. And I think one important point to understand is that I think biopsy grade reclassification is not necessarily all cancers are, those cancers are bad cancers. Some of those cancers can be still observed under active surveillance. Novel biopsy approaches may help reduce clinically insignificant prostate cancer detection. So I think in a very interesting study published by Brisbane et al. In European Urology, they showed that in a MRI detected lesion, there is going to be a gray area or a penumbra, perilesional radius or gray area, which shown here in this diagram. When you target that particular area, you can improve the detection of clinically significant prostate cancer, because targeted biopsies that include the penumbra has shown to have a higher risk of progression and harm if left untreated. So basically, they'll improve the detection of clinically significant prostate cancer when you target both the lesion as well as the perilesional radius or the gray area of that lesion. And that can improve the detection of clinically significant prostate cancer and can reduce the risk of progression for those patients. Determining prostate cancer aggressiveness in biopsy mapped to a clinically significant lesion holds great promise for more informed clinical decision making. So I think we know that prostate cancer is typically multifocal disease. And in this multifocal disease, the index tumor is typically defined as the highest grade or highest stage tumor, which is clinically most significant. Usually it is the largest tumor nodule. So I think that is what our traditional understanding is, that we need to define what is the index lesion. And I think that still holds true. And also molecular data has shown that these multifocal tumors tend to be independent group of diseases. But in this interesting study published by Mahal et al., they showed that in 14 patients with multiple primary foci and matched lymph node metastases, over half of the patients had multiple epigenetically distinct subclones, and the primary subclone from which the metastatic lesions originated. They applied then 25 DNA methylation probe signature or classifier, which predicted aggressive tumors that were significantly associated with presence of lymph node metastasis and tumor stages. So be on lookout for this type of more informed decision making that I think may occur as we, I think, move more and more towards artificial intelligence and molecular intelligence. And I think this is really an interesting area to explore. It has already been very well established that some of the tissue-based genomic classifier tests can also refine prostate cancer risk stratification and can help in decision of active surveillance versus definitive treatment or intervention. There are many classifier type of genomic tests available. Most commonly utilized are Prolaris by Myriad Genetics, Decipher by Genome Diagnosis, Oncotype DX, and then P10-ERG is also has been shown to have in some studies independent association. Some of these are also recommended by NCCN. But keep in mind that these tests are modeled to distinguish biologically aggressive tumors. We still do not have any test that can positively identify indolent prostate cancer. So routine use of this is not recommended, and these tests are still not thoroughly validated. So I think these tests have still some limitations, but they can be helpful to supplement, I think, clinical decision making in certain type of setting. And another important point to remember is that sampling can influence the result. If this test is performed on a non-significant area of the tumor, then the test may be likely showing a low risk molecular signature, while if it is done from the right area of the tumor, then you may get the correct information. So sampling can still influence the result of this test. That's important to understand. So finally, these are my take-home messages from this white paper, that we show that biopsy histology alone cannot reliably define indolent prostate cancer. We also make multiple arguments to show that why clinically insignificant prostate cancer overlaps with indolent prostate cancer, but they are not the same entity. But by incorporating additional variables, including patient's age, ancestry, imaging characteristics, specifically Pirate score and genomic variables that we discuss into traditional risk stratification models in biopsy, the detection of indolent prostate cancer in biopsy can be improved. So with that note, I again thank you for your attention. If you liked this white paper explanation, please like it, share with your colleagues, also repost it. And I would really appreciate if you can provide feedback as well. So that will help with the AI algorithm in YouTube. So thank you for your attention.